All right. So I think I will start. So for the sake of time, let me start now. So this is a continuation of the fetal anomaly series, and we are covering the central nervous system. Like I said the other day, that it is important that anyone who scans patients in the fetal medicine unit should be able to, should have a level of literacy when it comes to fetal defects. You cannot be scanning at a basic level if you are scanning the fetal medicine unit, because people expect you to scan at a high level. So this is the reason for teaching, and also for, we said this is a to the certification of our team members, because we need the theoretical base for our skill, because honestly, being able to pick that there's a problem without knowing what the problem is doesn't help very much. So you need to know what the problem is, or have an idea of what the problem is, that rather than to just say there is a problem on your baby. So this is the reason for these talks. I believe these talks will probably cover more than 90% of the defects that you may come across during your work. So today we are continuing. We covered up to holoprosencephaly last week. Today, I think to improve my connectivity, I've disabled my video there.
Recording in progress.
Sorry, I just want to make sure I don't lose this, so I've put in another device. So the next condition we are going to talk about is agenesis of the corpus callosum. So the corpus callosum, as you are, some of you may be aware, that we know that we've got the two brain hemispheres, the right and the left cerebrus. So they are connecting fibers that sort of link the two sides of the brain. Those fibers that link the two sides of the brain is what we call the corpus callosum. So you know from anatomy that there's a sagittal plane that separates the two sides of the brain, the right side and the left side of the cerebrum. So they are fibers, and those fibers are called the corpus callosum. So these fibers may be absent in totality in certain cases, or may be partially absent. So if they are absent in totality and those fibers are missing, we call that agenesis of the corpus callosum. If they are partial, then we call that partial agenesis of the corpus callosum. It is fairly common in fetal medicine terms. It's as common as 5 in 1,000. How does it come about? It comes from a number of factors. So it is heterogeneous. That means there are a number of factors that may be involved. But whenever we see this, the risk of trisomy 13 and 18 increases. So babies who are missing the corpus callosum, we have to do karyotype to check if they do not have trisomy 13 or 18, or at least we have to use the syndromic approach to look for other defects. The other etiology could be monogenic or teratogenic. Monogenic means single gene disorders. Then teratogenic means due to taking of substance that could be that are potentially harmful to the formation of the baby. So these are the possible etiologies. Whenever we see agenesis of the corpus callosum, how do we diagnose it? We diagnose it when we suspect that the corpus callosum, the cavum septum pellucidum is absent. So if we are not able to see the cavum septum pellucidum, then in that case we suspect agenesis of the corpus callosum. Of course, there is another condition called septo-optic dysplasia, which mimics this condition, but we would differentiate through what I will show you just now. What we will see is a teardrop configuration of the lateral ventricles. I'll show you on the follow-up images, this teardrop configuration of the lateral ventricles. Then we confirm the diagnosis through a mid-sagittal plane. in certain times, we may also need to do an MRI, fetal MRI to confirm the diagnosis. Then the management, what do we do? I've already told you that trisomy 13 and 18 are associated with this condition. So we need to offer the couple karyotype, to offer them amniocentesis so that we can know if trisomy 13 or 18 is underlying. The reason for trying to pick trisomy 13 and 18, we know that trisomy 13 and 18 are very bad aneuploidies. So that if somebody's got trisomy 13 and 18, the prognosis is very poor because these conditions are near lethal, trisomy 13 and 18. So this is very important for counseling, because if trisomy 13 or 18 is present, then the counseling message changes as compared to if we cannot pick these two conditions. Then, of course, genetic counseling in the case of monogenic inheritance. And also, like I said, that sometimes we may need the MRI to just make sure that what we are seeing is just an isolated case of agenesis of the corpus callosum, or we may have other underlying brain abnormalities. In isolated cases, the prognosis will say it is good, and it is poor if there are associations. This is why the ruling out of association is very important for these conditions. The neurological outcome is quite varied for agenesis of the corpus callosum, so that it is a very difficult condition to counsel the parents in terms of what will become of their child because of what we know about the condition. That certain babies will have an agenesis of the corpus callosum and they have probably normal intelligence or IQ, but some may suffer from neurological impairment. So it's quite varied, but generally the prognosis is okay for isolated cases of agenesis of the corpus callosum. Okay, right. So these are the images that you will see when you are doing your usual head circumference plane. You are going to miss the box of the cavum septum pellucidum. So there will be no box here. You know the image of the head circumference gives you a box of the cavum septum pellucidum, and you see the nice horns coming out on the side there. But in this case, you are going to miss it. And you are going to have this teardrop kind of fashion. And sometimes you get this three-layer, the trilaminar kind of appearance, or you get these three kind of lines which are parallel to each other. So this is what you see in cases of absent agenesis of the corpus callosum. The box, the cavum septum pellucidum will be missing. This is your first suspicion. But like I said, that we do not make diagnosis just based on this, because there is another condition called septo-optic dysplasia, where the cavum septum pellucidum is missing, but the corpus callosum is present. So how can we know then that the corpus callosum is present? Then we need to do the sagittal plane. So this is the sagittal plane that is showing us this is the corpus callosum here. So this is the rostrum, the genome, the body, and the splenic end of the splenium end of the corpus callosum. So the corpus callosum, this dark structure which I'm tracing there, is the corpus callosum. This is the cavum septum pellucidum underneath here. So that's the cavum septum pellucidum you see there. All right. So this is the sagittal plane, the one we use to get the profile view. If you go on this, if you are on the side of the sagittal suture line, you're not going to see this cavum septum pellucidum when you are doing profile. If you are doing a profile of the baby and you cannot see the cavum septum pellucidum, it shows that you are just off the midline. You are not strictly on the sagittal suture. Well, the sagittal suture allows the beam to go through and see the inner brain structures. But if you are seeing shadows while you still at the same time getting the profile, then you know that you are slightly oblique. You are not where you are supposed to be with your prop. So I'll just go through this is the rostrum part of the corpus callosum with the genu here. The genu is what we normally see. Remember, when we were doing the anterior complex, we're talking about the genu. When we were saying this is the corpus callosum, this is the genu we see because we normally get this plane when we are doing the head circumference. So we cut through the genu of the corpus callosum and we see the cavum septum pellucidum box as we are doing the usual plane for the head circumference, right? So this is the cavum septum pellucidum here, the genu, the body, and the splenium of the corpus callosum. This is a case where there is absent of the corpus callosum. You can see that we do not have even the cavum septum pellucidum. This fluid filled structure is missing. This is a case of agenesis of the corpus callosum. The same here. We see another case of agenesis of the corpus callosum. This is not the end. Then we go on now to demonstrate, because the corpus callosum itself is an artery which supplies it, which is a branch of the anterior cerebral artery called the anterior callosal artery. So this is a case of partial, where we are just seeing a little bit of it there, and a small cavum septum pellucidum, which is not quite prominent. So this is a case of just partial. How can you know it's partial? So when you put on the colors now, we are going to see in a case where the corpus callosum is present, we are going to see this artery here. This is the pericallosal artery, which I said is a branch of the anterior cerebral artery, right? So we see it here. So that's the pericallosal artery, which is following the corpus callosum. If the color of the machine as Doppler features are good, you can actually see it tracing the corpus callosum throughout. So this is the anterior callosal artery, which is normal in this case, and you can see the radial distribution of the vessels going up. And this is a case of partial. You can see it doesn't trace or follow like we see there. So this is a case of partial agenesis of the corpus callosum. And this is a case of absent. You can see the pericallosal artery is missing. We are just seeing this radial vessel there without any connection to the pericallosal artery. So this Doppler, we need it to confirm our diagnosis, whether we are dealing with partial or total agenesis of the corpus callosum. So that's corpus callosum agenesis. Right. So I'm not yet done with the cerebrum disorders. We'll come back to the cerebrum disorders when we do the neuronal migration. But now let's move to the posterior fossa, structures. We already know that when we are at the posterior fossa, we do measure the TCD, the transcerebellar diameter. We measure the cisterna magna, and on top of that, I think that is basically what we do. But extended neurosonography requires that I think I just want to go back to show you the standard images. I'm hoping I'm on this presentation. I'm sorry, I have too many presentations on CNS, so sometimes I mix them up. Let me come here. I think what I want to show. Sorry about this, or it's misbehaving my computer, but I want to come to right. So while on this image, this is the plane we are talking about. The transcerebellar plane allows us to assess the posterior fossa. So that's the plane. Look at how your probe should be when you are imaging the baby's head. So your probe should cut through a bit of the cavum septum pellucidum, the anterior horns, and all the way you can see there at the level of the cerebellum. This is the cerebellum here, which we are looking at. So that's the TCD plane. So this TCD plane, what does it show us? We are seeing the two lobes of the cerebellum, and in addition, we are seeing the vermis. So this is the vermis. The vermis, again, these are the two fibers. Those are the fibers that connect the two sides of the cerebellum, the two lobes of the cerebellum. So that's the vermis. If we, I'm not sure if I did put that plane there. I might not have put that plane there. But this is a plane which is just showing us the sagittal plane there. In the sagittal plane, we can still see the cerebellum, the fourth ventricle, and the midbrain here. And these are the diencephalons at the top there. So we can see the cerebellum, that's the sagittal plane. There is another plane which unfortunately I didn't put here, which if we continue to go down, we are going to see the fourth ventricle. Probably we'll illustrate the third ventricle as we do the pathology. Yeah, the fourth ventricle is being seen here where there's a dilatation. So that's the fourth ventricle, which is dilated in this case. We see it if we continue to go down, sort of like we're approaching the baby's neck, we'll see the fourth ventricle in that plane. Let me, yeah. So let's start with the dental walker malformations. Dental walker malformations, how common are they? They are as common as 1 in 25,000 to 1 in 30,000. Not very common, but we have seen quite a number in the unit already. And how do we diagnose it? Normally, there's an open fourth ventricle communicating with the cisterna magna. This is an expansion. There's an expansion of the posterior cranial fossa, and the vermis is small and upwardly rotated, greater than 45 degrees. Then we have upward displacement of the tendorium and topula is evident. I'll show you on the image what we mean by that. And there's late onset of hydrocephalus in greater than 50% of the cases. And the risk of chromosome abnormalities like trisomy 13 and 18 is about 35%. So that means the moment we say the risk is this high, if we see these conditions, it is imperative that we offer the couple amniocentesis for karyotyping. There is no fetal therapy for this condition. The prognosis is poor when there is associated malformations. But if it is isolated, then in that case, the prognosis is okay. So this is what we mean by dental walker malformation. You can see that the fourth ventricle and the cisterna magna are communicating. And you can see that the two lobes of the cerebellum are actually parted here. The reason why they are parted is because the vermis is now displaced by the fluid here because of the communication. It's not to say there's a Vermian agenesis. It is displaced. We may struggle to see it in the usual plane, but what we mean, this is what we mean when we are saying there's displacement of the vermis. So the fourth ventricle channel will look like this when we are looking now from the sagittal plane, and we can see that the vermis has been pushed upwards here. So that's the vermis that has been pushed upwards, so that the plane that we are taking is this kind of a plane here. That's the plane we are now taking when we are doing the transcerebellar plane, because the vermis is now pushed upwards and our plane is out of the vermis. So that's the plane. So the plane is going like this, cutting through the fourth ventricle and the cisterna magna, all in communication without the vermis in place. Normally the vermis is down here, but now it's pushed upwards because of the fluid. So this is what we are seeing here. Yeah. So that's a dental walker malformation. Within a dental walker malformation, there is something else called black pulse cyst, which is more like a variant of normal. So the instances are known for a black pulse cyst, but this is an open fourth ventricle communicating with the cisterna magna and a normal but upwardly rotated cerebral vermis. So that's the difference between a black pulse cyst and dental walker malformation. Whenever we see it, of course, we offer karyotype, and the outcome is very good in isolated cases. What happens is that you can see the position of the vermis now, how it is like compared to the other image. Yeah, you can see that in this case, the vermis is really pushed upwards in dental walker malformation, but in black pulse cyst, the communication of the fourth ventricle and the cisterna magna space. In the beginning, during embryogenesis, this communication is present, but it will be obliterated at some point. So cases of black cysts are cases where the obliteration did not happen, or there is failure of obliteration of the communication between the fourth ventricle and the cisterna magna space. So in other words, the persistence of the embryological communication of the two pouches here, the fourth ventricle and the cisterna magna, and we end up with a black cyst. So a black cyst probably is close to say it's a variant of normal because of its good prognosis if it is isolated. So this is what you see at the level of the fourth ventricle. Normally at the level of the fourth ventricle, we see the vermis in place here. But in cases of black cyst, there is no vermis. The vermis is slightly displaced upwards, as you can see, because this is our plane here, which we are going to be checking there. So at this plane, we'll get the lobes, but because the vermis is slightly displaced upwards, we are not going to see it. And all we are going to see are two sides of the cerebellar lobes. This is the sagittal plane to just show you the slight displacement of the vermis. Then another abnormality that we may see is the megacisterna magna or megacysteme. So in other words, the cisterna magna is enlarged in this case. The instant is unknown to say how common is it in a general population. We say there is megacysteme if the cisterna magna measures more than 10 millimeters, and the vermis and the cisterna magna are normal, and the cerebellar, sorry. The vermis and the cerebellar are normal. In this case, not cisterna magna. Sorry, forgive me for this. Association with chromosome abnormality is high. So whenever we see it, we need to offer the patient, the parents karyotype. In isolated cases, and where we have ruled out chromosome abnormalities, the outcome is good. So this is how it looks. So everything is normal here, but this space is enlarged. So this is the sagittal plane. You can see there in the sagittal plane that it's enlarged. There is no communication. You can now see the normal portion of the vermis, how it looks like in normal situations compared to the ones you were seeing just now. So this is the vermis here, and this is the cisterna magna here. The megacysteme in this case is dilated, and the vermis is not displaced. So this is our plane, which we normally do here. We're not doing TCD. So for you to distinguish black cyst and dental worker from megacysteme, you need to be able to see the vermis at the level of the fourth ventricle. So if you can't see the vermis in place at the level of the fourth ventricle, then it's either we are dealing with a case of a black cyst or a dental worker malformation. Yeah, so that's megacysteme. Then Vermian hypoplasia. Vermian hypoplasia means the vermis is missing. The instances are known again. It is open. This is where we have an open fourth ventricle apparently communicating the cisterna magna. The posterior cranial fossa is not expanded, and the vermis is small and upwardly rotated to less than 45 degrees. The tendorium tocula positionally normal. In this case, we need to do karyotype, and no fetal therapy is required. However, if it is isolated, babies may be asymptomatic after birth. Okay, unfortunately, I don't have a picture to illustrate here, but you are going to see that there's a gap. There's no enlargement of the cisterna magna space, but the two lobes of the cerebella are separate from each other. Even when you look at the sagittal plane, this is what you are going to see: a normal cisterna magna, just a slight upward displacement, but the angle is less than 45 degrees, this angle here. And this is to illustrate again, that's Vermian hypoplasia. So it's not totally absent, but it is smaller than what it should be. There are less fiber than they should be, like in the case of partial agenesis of the corpus callosum. Then arachnoid cysts. Again, the instances are known in terms of how common are these, but these are this is a retrocerebellar there could be two types. There's one that happens within the cerebrum, within the cerebrum area. Then we have the one that happens within the posterior fossa. So if they happen within the posterior fossa, they will appear as a pseudo-lucent cystic mass. And sometimes if it is too large, it may compress and displace cerebella and also obstruct CSF circulation, leading to secondary obstructive hydrocephalus. The management is conservative, no fetal therapy. The prognosis is overall good for arachnoid cysts. So this is how they look, arachnoid cysts. Sometimes they may look very big. For you to be able to distinguish this from the other pathologies, you need the other plane, the sagittal plane, so that you can see that this is the whole circumscribed mass, and also the other structures are present. They may be squashed, but they will be present. We have seen way larger masses than these ones in terms of the arachnoid cysts. Sometimes they could be within the cerebrum here, the arachnoid cysts. Then rhombencephalosynapsis. Rhombencephalosynapsis is a very rare condition, but I think we've seen one or two cases now. We've got one or two cases of them. I think one of them was a case of trisomy 18. These are hypoplasia. This is a case where there's a hypoplastics of the cerebellar hemispheres, which are fused on the midline. In other words, we do not see the vermis in these cases. It's just two cerebellars which are fused together. They may be associated with absent septum cavum septum pellucidum, abnormal gyration and hydrocephalus, and the risk of chromosome abnormalities is low. The management is normally conservative, no fetal therapy. The prognosis is poor. So if the prognosis is poor, that means we can potentially offer the couple the option of termination of pregnancy. This is rhombencephalosynapsis. Look at this TCD, very tiny. Look at the cerebellar lobes, they're just fused with each other. In this case, of course, there was association with ventriculomegaly here. But you can see here that just fused cerebellars there. That's rhombencephalosynapsis. Then Chiari tumor formation. The Chiari tumor formation is normally part of the myelomeningocele complex. So it is fairly common, 1 in 10,000, the Chiari tumor formation. How do we diagnose it? We are going to see a lemon sign and obliteration of the cisterna magna and a banana sign. In most cases, it is in association with the open spinal bifida or myelomeningocele. The chromosome abnormality association is very low and is associated with moderate to severe ventriculomegaly in about 70% of the cases. We'll discuss it more under spinal bifida, but to just show you some of the features. When you are saying a lemon, we are saying this is scalloping. If you check here, there's scalloping of the frontal bones here. This scalloping, this tapering towards the front, we are seeing. This is what gives us the lemon. The lemon you are talking of is the European lemon, not our lemon. You know, our pimpled lemon. It doesn't look like this. But if you go into supermarkets and look for these European lemons, they are tapered to the front. So this is where the lemon head comes from. If you see that the scalloping of the frontal bones here, it's called a lemon head if the head of the baby looks like this. Then when you try to look at the cerebellum, you can see that the cerebellum is curved. This is where the banana, Professor Kipros nicknamed it the banana sign because of this. You can see there that it's looking like, you can see, it's looking like a banana, right? This is the curved side of the banana, then the bulge side of the banana. So this will result in the obliteration of the cisterna magna. Why are we getting this? Because the brain is being pulled by the posterior fossa brain here is being pulled by the tagged spinal cord. This is why it is obliterating the posterior fossa. So that's a lemon head, banana side, and of course, ventriculomegaly here, due to the obstruction at the level of the foramen magna. Right. So I've gone through the posterior fossa defects. I'm now going to the neuronal migration disorders, neuronal proliferation and migration disorders. I'm not going to go much into embryology, but neurons, during the embryogenesis, they start somewhere else in the brain. And then they have to migrate as the baby develops, mainly in the third trimester. This is where this neuronal migration occurs. So the brain has to, the baby has to, the neurons have to migrate to their final resting place. So this is where the neuronal migration issue comes from. So when you are saying neuronal migration disorders, you are saying for certain neurons, that migration process may be arrested by one reason or another, and the neurons do not arrive at their final resting place. So this is where these disorders come from, where the neurons have failed to move to their final resting place where they will operate from. So we start with microcephaly, a very bad condition. It occurs in 1 in 6,250 to about 1 in 8,500. Fairly common in fetal medicine terms. I think we've seen 1 or 2 cases ourselves of microcephaly, or more actually. The diagnosis, if the head circumference is below the 3 standard deviation, which should be the third center, right? If I'm not mistaken, I have to check. But this is a small head, which is below, should be below the third center. A head circumference below the third center from the mean of the gestational age, or a 3 standard deviation. Normally, there's a slanting forehead on mid-sagittal plane. The risk of chromosome abnormality is very high. Whenever we see microcephaly, we want to do karyotype. Prognosis depends on the etiology and the association with the other abnormalities. So whenever you measure the head circumference, look at the comparison in this case between the head circumference and the AC. From your scanning so far, you are now aware that it's only in third trimester term where the abdominal circumference approaches the head circumference, but the head circumference is always the bigger one, right? So if you do your measurement in a woman who is not term, at term, normally these structures sort of come together for certain babies around 40 weeks. But before that, the head is always supposed to be bigger than the abdominal circumference. But of course, there are always exclusions, right? In cases of poorly controlled diabetes mellitus, surely the tummy may grow bigger, right? So the context matters. Or in cases where we have maybe bowel dilatation or an abnormality within the bowel, or maybe we have ascites with the anasaka and so forth. So these kind of situations may change this statement, but barring all that, the tummy should not be bigger than the head circumference. If you see that the tummy you have done is bigger than the head circumference, and the tummy is appropriate, but the head is small for gestational age, then we need to interrogate that baby for microcephaly, right? So if you do the usual profile, you can see that this is a flat forehead, right? Look at how it looks like. Normally, they also have a microthummy, a small chin, and this is how the babies look like at birth. The head is small, it's a tiny head, and a small brain, right? The prognosis is very poor with microcephaly. They normally have severe neurological and mental handicap. As a result, we offer them termination of pregnancy as an option or expectant, depending on the couple's preference. Hemimegaencephaly. I know these may be new terms, but we have to learn them because in fetal medicine, the incidence is very low for the hemimegaencephaly. What is it? It is an asymmetry of the cerebral hemispheres with dilatation of the lateral ventricles on the affected side and a shift of the midline. The risk of chromosome abnormality is very low. Prognosis very poor with severe mental retardation, seizures, and hemiplegia. Hemiplegia means paralysis of one side of the body. So this is how it looks like. You can see that there's unilateral dilatation here, and this part of the brain, this is the midline. So if you measure the two hemispheres, you can see that this one is hypertrophied, and the midline is displaced towards the small side, right? Because the brain is enlarged one side. So we call that hemimegalencephaly. Lissencephaly. The instance is unknown, and this is an absence of the normal present sulci and lack of opicularization of the Sylvian fissure or early abnormal sulcation. So how can we identify it? You remember we talked about the Sylvian fissure last week, that the gap of the Sylvian fissure should always be seen. So if we see the Sylvian fissure developing the way it should and the angle changing the way it should, then you know that normal gyration and sulcation is taking place. But if we don't see the Sylvian fissure, or we see a retarded Sylvian fissure in terms of its development, then we begin to suspect Lissencephaly. You will see how the Lissencephaly heads look like. There may be mild ventriculomegaly present, and the risk of chromosome abnormality is low. An MRI may be required, to fetal MRI, brain MRI, to help cleanse the diagnosis. And genetic testing using FISH, looking for Miller-Diecker region deletion, may help in clinching the diagnosis. The prognosis, again, is very poor. So this is how a mesencephaly head looks like. This is the normal kind of brain. You can see the 20 and the 30. Here we are looking at the ospitoparital fissure here. But when you now look here, we can see that the Sylvian fissure is too open here. It's not its usual appearance. There's no angle which you are seeing here. So the loss of the angle and the poor formation of the Sylvian fissure is what will lead us to suspect Lissencephaly, where we lose the angle and we don't see the normal development of the sulcation and gyration. And when you look at the sagittal plane, it will look like the skull is too large for the brain. You are going to see this large fluid space around the brain here, and you are going to see a very smooth brain surface. This is the coronal plane, and this is the sagittal plane. You should not see fluid. You guys have been doing this plane. If you see that there's fluid underneath the skull, then we need to query the diagnosis of Lissencephaly, where the brain is very smooth walled here, and there's fluid, tumor cerebrospinal fluid. It's like the skull is too large for the brain kind of situation. So this is not normal, this kind of appearance. So that's Lissencephaly. We go to another condition called Schizencephaly. The instance is unknown. It's presence of CSF fluid clefts of cerebral hemispheres that extend from the cortical surface to ventricles. That is from pia mater to the ependyma, lined by dysplastic gray matter. The risk of chromosome abnormality is low, and the outcome is variable in closed forms and poor in open forms. TOP is an option in case of open bilateral Schizencephaly. So in Schizencephaly, what you are saying that we have these fluid channels which are communicating from the outside of the brain to the ventricles. Look at them. So you can see here there's total destruction here of the brain tissue, and we now have the ventricles communicating with the outside of the brain here. So this is Lissencephaly. So yeah, very bad condition, as you can see. So when they are communicating like this, they are very bad, and we can offer termination of pregnancy. Hydranencephaly. What is hydranencephaly? It occurs in 1 to 2.5 in 1,000, in 2,000, in 10,000 newborns. Normally, this is a huge fluid collection which fuels the whole cranial activity with no recognized cerebral cortex. The fox is present, as well the meninges, the thalami, the basal ganglia, the brainstem, the cerebellum are normal. And the risk of chromosome abnormality is low, and termination of pregnancy is a viable option because this baby does not have the cerebrus. The two brain hemispheres, the cerebrus are missing. The prognosis obviously suspect is very poor. So this is how it looks like. Sometimes it may confuse with holoprosencephaly, but in this case, we will have a midline, the false cerebri. That's a distinction feature. The good thing is, even if you miss and you think it's hydranencephaly instead of holoprosencephaly, the good thing is that you're not going to cause harm because both of them have a poor prognosis. And the management is offering termination of pregnancy or expectant. So you're going to see a brain, a head without the cerebrus here. And the false cerebral will be present. And it's all fluid. And the meninges will be at the end here. This normally happens because of earlier blockage of the internal carotid artery, which supplies the two cerebrals. So when it's due to thrombosis of the internal carotid artery during the formation of the brain, and the whole cerebrals undergo autolysis, vascular autolysis. Porencephaly. The incidence is very rare. Diagnosis. These are cystic and which are usually unilateral lesions communicate with the ipsilateral ventricle and or arachnoid space. The risk of chromosome abnormality is very low. The prognosis depends on the extension of the lesion, and in most cases, the outcome is poor. The psychomotor maybe psychomotor retardation and hemiparesis or epilepsy. So these are the cysts. You can see the porencephaly cysts within the brain. There are the cysts. There you can see they are different from the Lissencephaly cysts. So we can see they are normally unilateral, the cysts within the brain. Right. I think I'll stop here. For the sake of time, then we will continue. You can see that the CNS is a very big topic. I think it's the biggest topic of them all. I'll stop here. Then we can continue next week. I think we should be able to finish. Next week, we're going to do the neural tube defects and the spinal cord defects, the spine defects. So I'll stop here. We have covered posterior fossa. We finished the upper defects, CNS defects, and we did the posterior fossa. We also covered neuronal migration disorders. I'll stop here. Then next week,